So let's continue with the glomerulonephritis, and in today's lecture we will discuss further the inflammatory process in the glomerulus. And because the inflammation in the glomerulus is mostly immune mediated, so there are three main mechanisms how the inflammation is brought into the glomerulus. One is immune complexes. Second is antibody mediated, which is like ANCA or anti-GPM. And third is a complement mediated alone without immune complexes or without antibodies. And that's example is C3 nephropathy. These immune complexes are basically antigen antibody complexes which circulate freely in the blood, and they deposit in various tissues, including the glomerulus. So glomerulus is not the only tissue which will be involved in the immune complex diseases. There will be it can be a multi-system disease if it's an immune complex mediated glomerulonephritis, such as patient may have a small vessel vasculitis, or patient may have a skin rash or purpura, and patient may have arthralgias and arthritis and other splenomegaly and other findings of immune complex manifestations. When they deposit in the glomerulus, within the glomerulus, the deposition of the immune complex can be at one of the four places. One, it can be in the mesangium. Second, it can be in the subendothelial location between the capillary and basal membrane. Third, it can be intramembranous. And fourth, it can be subepithelial between the basal membrane and the Bowman's capsule, right? So depending upon basically the deposition of the immune complexes in various these locations depends upon mainly the size of the immune complex, and also depends upon the charges of the immune complex, because they are mostly proteins. And the collagen in the basal membrane, they are also charged. So there may be some attraction or repulsion forces. Usually the largest immune complexes, they settle in the subendothelial location. They are closer to the blood and they are most immunogenic. So they induce strong inflammatory response. The subepithelial are usually the smallest one, same as the mesangial one, they are smallest one. They are subepithelial are away from the blood, they are less immunogenic, and they cause less inflammation as compared to the subendothelial. Okay. So these immune complexes, they are basically type 3 hypersensitivity reactions. So there are four types of the hypersensitivity reactions: 1, 2, 3, and 4. Type 1 is basically allergic reaction mediated by the IgA. Type 2 and type 3, they are antibody mediated. Okay, and type 4, they are cell mediated immune reactions such as granulomas and lymphocytic inflammations. Now, when the type 2 and type 3, they are the mainly one which we need to understand here, because we are dealing with the antigens and antibodies. Okay, we're not dealing with the cell mediated immunity here, but we're dealing with antibody mediated system. So type 2 and type 3, they are basically the same. The only difference between these two is if the antigen is a part of the body tissue. If antigen is a part native to the body cell, any body cell, and antibodies are targeting that antigen, then it will be type 2 reaction. Type 3 is basically a free circulating antigen. Most of the time it's unknown antigen. It's not part of the human body tissue. Okay. It may be infectious antigen or drug antigen or cancer antigen or any other antigen, which is not normally a part of the body tissue. And antibodies, they combine with it and they're freely circulating as immune complexes. So that is a type 3 reaction, also called as a serum sickness reaction. So immune complexes are basically type 3 reactions. Okay. These immune complexes deposition within the glomerulus are detected on the biopsy by immunofluorescence. Okay, and they are very helpful clues when we do the renal biopsy. Immunofluorescence tells us where is the deposition and what sort of deposition it is. It is just antibodies, is immune complex, is a complement, or all of the three. So based on that, the renal biopsy helps to diagnose further about the type of the glomerulonephritis. Okay. When the patient has immune complex mediated glomerulonephritis, patients' serum complement levels, they are often very useful because immune complexes, they mediate the inflammation through the complement system. So serum complement level is used up, and usually the level of the serum complement may be low. Okay, so low serum complement level in the setting of glomerulonephritis usually indicates this is immune complex glomerulonephritis. Okay, normal serum complement may be there because of the rapid turnover, and if it's not extensively used up, it may be in the low normal range or it may be completely normal. But even if it's normal, but we can still find the immune complexes and complement deposition within the glomerulus, and that will indicate that this is immune complex disease. Okay, so presence of antigen antibody combination in immune complex in the glomerulus plus complement system in the glomerulus, they are clues for the immune complex mediated glomerulonephritis. And the complement system involved in this case is the classical pathway, which starts with C1, and it also involves C4 as well. So C3, C4, usually we check for C3 and C4, and we also check for the total complement level, which is CH50, and we can also check for the membrane attack complex. Okay, and subsequently we will discuss in bit more detail that sometimes we need a bit more elaborated testing for these complement system of the blood. For example, when we check for the C3 nephropathy, C3 glomerulopathy, we ask for a bit more detail like C3 convertase and C3 nephritic factor and C3, C4 and all those things. We will talk about them when we go to the membranoproliferative glomerulonephritis. But for now, we need to understand that the immune complex mediated inflammation depends upon the size of the immune complex and location of the immune complex, and it also is mediated through the serum complement system. And the serum complement is the one which will bring the inflammation there. Okay, so that is about the immune complexes in the glomerulus. Now, next we need to elaborate is the inflammation itself. Okay, now when the inflammation is there in the glomerulus, it as we discussed in the previous lecture, it causes four consequences. First, it causes damage to the capillaries with causing glomerular hematuria. Second, it will cause compression of some of the capillaries, which will cause reduced blood flow and fall in the GFR and renal failure, or retention of the waste products in the blood. And thirdly, it will cause proliferation because inflammatory cells, they produce growth factor and they cause proliferation. And the proliferation of the native cells, the cells which are part of the glomerulus, which includes mesangial cells, capillary endothelial cells, and the Bowman's epithelial cells. So the easiest cell to proliferate is the mesangial cells. And if you look at this diagram, here this is the proliferation. Now, if you look at this diagram, the mesangial, which is shown in the blue, okay, there's quite extensive proliferation of the mesangium. And if you look at the capillaries, the one of the capillary which is completely occluded due to the endothelial proliferation, mesangial cell proliferation and endothelial cells, they are the commonest one to proliferate. Okay, the Bowman cells, the one in green in this picture, they are the least likely to proliferate. They are most resistant cell to proliferate. They don't like to proliferate because once they proliferate, they make a crescent. They will fill up the Bowman's capsule and that look like a crescent. And that physically occlude the connection between the glomerulus and the tubules. Okay, and the patient goes into the rapidly progressive renal failure. We'll come back to the crescents in a few minutes time. Okay, so the easiest cell to proliferate is a mesangial proliferation. Some of the glomerulonephritis will just have a mesangial proliferation. One of the example is the IgA nephropathy, which causes predominantly mesangial proliferation with very minimal endothelial proliferation. Okay, some of the glomeruli will have predominant endothelial proliferation and less mesangial proliferation, and some will have endothelium and mesangial proliferation both. Okay, that's called as mesangiocapillary proliferation, right? And this proliferation is detected as in the renal biopsy as a as a hypercellularity. And if we, as a biopsy report will say there's a mesangial hypercellularity, and they will further elaborate there's a mesangial proliferation, or there's endocapillary proliferation, or there's a mesangiocapillary proliferation. Endocapillary mean endothelium, and mesangiocapillary mean mesangial plus capillary endothelium. Okay, right? Unless specified, if they just use the term proliferation without specifying is it a mesangial or endothelial, so that most of the time means mesangial proliferation. Okay, right? Now coming to the crescent formations, crescents are basically a proliferation of the Bowman cells, and when they proliferate, they will fill up the whole Bowman cup, and the whole glomerulus will be physically obliterated. This is how the patient goes into acute renal failure and goes into the dialysis dependent disease. Okay, depending upon the number of the glomeruli involved, if more than 50% glomeruli are involved, okay, that means a severe disease. So crescent formation is a marker of a severe disease, and the number of the glomeruli which have the crescents indicates the further severity of the disease. Okay. The more is the number of the glomeruli with crescent, the severe is the disease. Okay. Now these crescents in the beginning they are made up of cells and fibrin and the inflammatory complement proteins. Okay. With the passage of the time, they will organize into the fibrous tissue, and they are called as fibrous crescents. So cellular crescents and the fibrous crescent, there are two types of the crescent. Cellular crescents would indicate that the inflammation is still active. Okay? Whereas the fibrous crescent means is a burnt out disease. So we take the proportion of how many glomeruli have a cellular crescent and how many cells have a fibrous crescent. Generally speaking, more is the number of the fibrous crescents, less is the presence of the active inflammation, and less will be the benefit of any immunosuppressive therapy. More is the number of the cellular crescents in the glomeruli, higher is the chance that this glomerulonephritis will respond to the immunosuppressant more likely. Also, when there's a significant number of the crescent formation, the disease is already approaching the dialysis dependency. Okay, the patient is already heading toward the dialysis, and we need to act urgently. So usually, if the number of crescents is significant on the renal biopsy, that is one of the indicators that in addition to the immunosuppressive therapy, such as methylprednisolone pulse plus cyclophosphamide pulse, we also add plasma exchange therapy at the earliest possible when we see this is a crescent formation or there's a crescentic glomerulonephritis. This crescentic glomerulonephritis is basically a glomerulonephritis with significant number of the crescent formation. Okay. Now, this crescentic glomerulonephritis, which is also called as RPGN, rapidly progressive glomerulonephritis, remember it's not very rapid. It takes few weeks, at least 2 to 4 weeks from the beginning to become a dialysis dependent disease. Okay, so this RPGN should not be taken that a patient from the start of the symptom, patient will go into dialysis dependency next day. No, it's not that quick. It's subacute. Okay, it takes 2 to 4 weeks because these cells they are very slow to proliferate, so they don't fill up the whole cup in one single day. They will take weeks, many days, or at least weeks to make significant number of the crescents. Okay, we also need to remember that the formation of the crescents or the crescentic glomerulonephritis is not a diagnosis per se. We'll talk about crescentic glomerulonephritis down the track as a separate topic as well, but because we're discussing and dissecting the clinical concepts of the GN, so it's important to mention here that crescent formation is not a primary diagnosis, is always secondary to a severe inflammation in the glomerulus. Okay, and the most common cause of crescent formation in the glomerulonephritis is oncovasculitis. 70 to 80% of crescentic glomerulonephritis is caused by oncovasculitis. So if the patient has significant number of the crescents in the glomerulus and there's onca deposition in the glomerulus, even if the serum onca level are normal and there's no other systemic manifestation of oncovasculitis, this is a very strong clue that this patient has oncovasculitis related glomerulonephritis. The second common cause of crescentic glomerulonephritis is anti-GBM syndrome or good pasture syndrome. The reason why these are the two common causes of the crescent formation is because both of these type of glomerulonephritis, both the ONCA and anti-GBM, they are antibody mediated, which causes direct attack on the capillaries and causes rupture of the capillaries. And when they cause significant rupture of the capillaries, when they cause the significant rupture of the capillaries, okay, that will lead a huge amount of the fibrinogen and fibronectin into the Bowman space. Remember, plasma proteins, when they're in the blood, they are very good for the body, but the moment they leave the blood, they act as a growth factor. And the bigger is the size, the bigger is the growth factor. And fibrinogen is the biggest protein. So fibrinogen causes huge proliferation when it's there in the significant amount. So for the Bowman cell to replicate, we need a significant amount of the fibrinogen in the Bowman space. And that happens when there's a capillary rupture. Okay. Just nephrotic syndrome doesn't leak the fibrinogen. Fibrinogen is big enough. It usually doesn't leak when there's a single layer damage. Okay. It leaks more when there's a capillary rupture. So because both the oncovasculitis and anti-GBM, they cause physical rupture of the capillary, so they cause more leakage of the fibrinogen, and that's why these are the two commonest causes of crescentic glomerulonephritis. Rest any proliferative glomerulonephritis, which is due to the inflammation. Okay, any proliferative glomerulonephritis can cause crescent formation when it's severe enough. Mild to moderate degree of proliferative glomerulonephritis, they usually don't explain crescent formation. Okay, and severe proliferative glomerulonephritis is usually needed to explain the significant number of the crescent formation in any proliferative glomerulonephritis. What's the clinical significance of this fact? For example, patient has a lupus, and the renal lupus on the renal biopsy is otherwise mild to moderate. It's not severe, okay? But the patient has a significant number of the crescent formation. Now, we cannot explain these crescents based on the lupus nephritis. This patient may have coexisting lupus with anti-GBS, glomerular basal membrane antibodies, anti-GBM antibodies, or this patient may have a lupus with coexisting oncovascular. So presence of crescents out of proportion to the inflammation in the rest of the glomerulus usually means we need to find, are we missing any oncovasculitis or additional pathologies such as good pasture syndrome. So okay. Oncovasculitis and good pasture, they are the two most common cause. 70 to 80% of crescents are because of oncovasculitis, 10-20% are because of the good pasture, 5 to 10% are mainly because of the remaining proliferative glomerulonephritis, and that only if they are severe enough, not when they are mild to moderate. They cannot explain significant number of crescents when they are mild to moderate. If that is the case, if you find a significant number of crescents in a patient with proliferative glomerulonephritis, which is mild to moderate, we need to find additional pathology. Okay, so that is crescents. And the crescent, the clinical significance of the crescent is that we need to add plasma exchange very early in the course of the disease. We shouldn't wait for the methylprednisolone and cyclophosphamide to kick in. We have to add plasma exchange right from the beginning, and then once the patient start improving and those antibodies level in the blood are negative, then we can stop the plasma exchange. Okay, so that is the significance of the crescents out of the proliferation. Okay, another important fact is when there's a proliferation, we're still on the proliferation because proliferation is a big topic. because of the proliferation, you can see when there's a mesangial proliferation, it expands the mesangium, and when it expands the mesangium, it will compromise the adjacent capillaries. It will press on the adjacent capillaries. Similarly, when there's endothelial proliferation, it will occlude the capillary lumen. Similarly, when there's a crescent formation in the Bowman's capsule, it will not only occlude the Bowman's space, but it will also press on the capillaries. So all this proliferation, it also compresses the remaining normal capillaries of the glomeruli and cause further fall in the GFR. Okay, so that's another consequence of the proliferation to cause renal failure, right? Now, next important concept we need to understand is the concept of proteinuria and the hematuria. We already discussed that if there's single layer damage, it will cause proteinuria. If all the three layers are damaged, then it will also cause glomerular hematuria. Now, remember for the proteinuria, depending upon the size of the leakage, for example, if the disease is very mild to moderate, it will leak the smallest protein, which are called as which is like albumin. Albumin is one of the smallest proteins. So albuminuria is the first thing to happen. Okay? And the second, the more is the leakage, the bigger size of protein they also start leaking into the urine. Okay, so remember the figure of 30, 30. Less than 30 milligram per 24 hour is normal. Everybody, even normal people can lose some proteins in the urine, but they should not be more than 30 milligram. Okay, 30 and between more than 30 and less than 300 is called as microalbuminuria or microproteinuria. Is mainly the albumin. Okay, right? And between the 300 and 3000 is macroproteinuria or non-selective proteinuria. Okay, because the other albumin and plus other protein, they also start coming in the urine when there's a, and more than 3000 is nephrotic range proteinuria. Okay, so 30, 300, 3000. Remember the figure of 30 and keep adding 0. 30, then add 0, 300, then add another 0, 3000. Okay, less than 30 is normal. Between 30 and 300 is micro. Between 300 and 3000 is macro or non-selective proteinuria or non-subnephrotic proteinuria. And more than 3000 is a nephrotic range. Now, why this proteinuria is important? Numbers are not important, but why this is important? We don't care about the proteinuria because we are losing protein. But these proteins, when they leave the blood, they act as a growth factor. So when they are coming in the glomerulus, they will act as a growth factor for the mesangial cell. And these proteins, they will cause mesangial sclerosis. They will cause glomerulosclerosis. So this is the main reason we need to control the proteinuria, because ongoing proteinuria, depending upon the quantity of the proteins, will induce the fibrosis in the glomerulus. That's the main fear. That's the main concern. Otherwise, if you're just losing the protein in the urine, we can replace them by the diet. We don't need to be crazy and use strong immunosuppressant just to control the proteinuria, but we do it because we know if this proteinuria is uncontrolled, it will cause glomerular fibrosis and glomerulosclerosis. So that's the main reason the proteinuria is need to be controlled. And usually in the nephrology practice, any proteinuria more than 500 is taken as seriously. And if the patient has a nephrotic range proteinuria and it drops down to less than 500, then it's taken as a remission. It's not a complete remission, but it's taken as a remission, because making the proteinuria to absolute back to the normal would need a very high doses of immunosuppression, when the side effects may be more harmful than the benefit. So usually the target range of the proteinuria in patient, when we treat them for in nephrology, we try to bring it below 500 milligram per day. Okay, so that now these proteinuria from the glomerulus need to be differentiated from the proteinuria due to tubules, and proteinuria can also happen because of the lower urinary tract as well. For example, there's an inflammation in the lower urinary tract, UTI, or there's a cancer sitting in the lower urinary tract, or there are stones irritating the mucosa and causing ulceration and exudation in the lower urinary tract. So all these can also leak the proteins. Okay, and similarly, if there's a tubular disease, that can also cause proteinuria. So how to differentiate? Remember, Tubular proteinuria is almost never albumin. Tubules have small quantity of non-albumin proteins which are basically required for the normal functioning of the tubules. Okay, and they're present in the lumen. For example, one of the example of the tubular protein is a TAM horsefall protein, okay, which is used for the cause formations. Okay, so tubular proteinuria is almost never albumin, number one. Number two, it's never more than 1 gram. So any proteinuria which is albumin or which is more than 1 gram is almost never tubular, is not explained by the tubular disease. It's almost always glomerular. Proteinuria from the lower urinary tract uh, pathology is usually accompanied with the other clues of the, for example, there will be pain or gross hematuria or symptoms of the infection and those things. Okay, the clues for the glomerular hematuria. Remember, glomerulus is a bunch of capillaries. When we will rupture the capillaries, it will leak only a small amount of the blood. So glomerular hematuria is usually microscopic. Okay, that's one clue. It's never gross or macroscopically visible. If you see a fully urinary bag full of blood, this is most likely low urinary tract hematuria rather than hematuria due to glomerulus disease. Glomerular hematuria is often detected by the lab. It's not grossly visible, it's microscopic. Okay. Because of the alteration in the color, it may change the urine color to Coca-Cola, but it's not grossly red. Grossly red urine is very unlikely to be glomerular. Okay. They never bleed to the shock, or they never bleed to the point that the urine becomes grossly red or hematuria. That's one thing. Second, the size of the red cell is bigger than the size of the renal tubule. So when the red cells they leak from the glomerulus, they pass through the renal tubules. The red cell has to squeeze, so they become dysmorphic or crenated. So glomerular hematuria has a crenated red cell or dysmorphic red cells. Yeah? And thirdly, because the size of the red cell is bigger than the size of the lumen of the tubule, so the red cells have to make a queue. So they queue up, and when they make a queue, one after the other, they get stuck with each other with the help of this protein, TAM horsefall protein. And this queue of the red cells, which are deformed and crenated, is called as red cell cause. So presence of the red cell cause in the urine, dysmorphic red cells, crenated red cells, and microscopic hematuria, with or without other clues for the glomerular disease, usually mean this is a glomerular hematuria. Patient will often have some degree of proteinuria as well, because when we rupture the capillaries, we not only leak the blood, we not only leak the red blood cell, we also leak all the other components of the blood as well. So there's a protein leak, and also the patient will have abnormal uh, glomerular function such as fall in GFR. So that is a glomerular hematuria. And if it's a proteinuria, is called as nephrotic syndrome. Okay, when it's more than 3 grams per day, and if it's predominantly the hematuria, is called as nephritic syndrome. So we divide the glomerulonephritis into two types, two main subtypes. One is nephrotic, which is mainly proteinuria, and other is a nephritic, which is glomerular hematuria. Some of the glomerulonephritis will have combination of both, nephrotic and nephritic, such as membranoproliferative. Okay, we'll come to that. Okay, so that is how they are classified. Now the consequence, one other concept we need to discuss about the glomerulonephritis is a focal versus diffuse. If you look at these two pictures, if you look at the left one, this one on the right, out of the 9 or 10 glomeruli, only a few of less than 50% they are involved, and which the glomeruli which are involved, there only some part of the each glomerulus is involved. Okay, that's a focal and segmental. Okay, if you look at the second picture on this side, this one, okay, now each glomerulus which is involved is almost completely involved, and if you look, more than 50% glomeruli are involved. So this is called as a diffuse involvement. So this difference between focal versus diffuse. Okay. An ultimate consequence of each glomerulonephritis, if it's not properly controlled, that will end up in fibrosis, like the third picture shows, and the kidneys it causes diffuse shrinkage of the kidneys. Okay. Now, because of this this fibrosis in the glomerulus is diffuse. Is a uniform fibrosis involving all parts of the kidney and involving both the kidneys. If the glomerular fibrosis or if the renal fibrosis or renal shrinkage is only in one kidney or only in a small part of the kidney, the rest of the kidneys are normal, we cannot explain this based on the glomerulonephritis. It may be a pyelonephritis or nephritis, some other anatomical cause. Fibrosis because of the glomerulonephritis involve both the kidneys bilaterally in all the areas symmetrically. Okay. So if you find one kidney is shrunken and the other kidney is normal, this is not glomerulonephritis. Or if you find only a part of the kidney is shrunken and the other is fine, this is not glomerulonephritis. Both the kidneys should be shrunken if it's because of the glomerulonephritis. The similar uniform bilateral symmetrical fibrosis also happens in chronic tubular diseases. Tubular atrophy or tubular interstitial nephritis will also cause uniform bilateral symmetrical fibrosis. So whenever the kidney shrinkage is bilateral and is symmetrical, it could be because of the glomerulonephritis or it could be because of the chronic tubular interstitial nephritis. But if the glomerulonephritis uh, is not the cause, or the tubular interstitial nephritis is not the cause, then the fibrosis it will be asymmetrical only in one kidney, or even if it's bilateral, it will be grossly asymmetrical, such as pyelonephritis or renal stones or whatever, any other cause of renal volume loss. Okay, so when the kidney goes into this shrunken state because of the fibrosis, now this means usually the disease is end stage, and now there's no point. Biopsy at this stage may not be very useful. Number one. Number two, this will be immunosuppression therapy is not going to work because fibrosis has already taken place to a significant extent and it's not going to help. Okay, this stage will be only at a very advanced disease. Okay, the early detection of the fibrosis in the kidney is done by the renal biopsy. If you do a renal biopsy and it shows a major part of each kidney is fibrosed, major part of each glomerulus is already sclerosed, then that means the disease is already burned out and is advanced disease. So that's the significance of the glomerulosclerosis. Okay, when the glomerulosclerosis is partial, focal, the remaining glomeruli which are not sclerosed yet, which are normal, they will try to compensate. They will have increased blood flow, increased intraglomerular pressure, glomerular hyperfiltration, and they will start leaking proteins ultimately. So partial or focal glomerulosclerosis usually causes nephrotic syndrome, usually causes proteinuria, even if the remaining kidney is normal, is not involved by the disease process, but it's just because of the compensatory hypertrophy and increased workload and increased intraglomerular pressure that they start leaking proteins. So focal segmental glomerulosclerosis causes proteinuria. When the glomerulosclerosis is diffuse, involve both the kidneys, involve most of the glomeruli, then it ends up end stage renal disease, which will need dialysis. I think we'll stop here. I'll be more than happy to take a question. We can stop the recording now.